Right. So we have a 60-year-old female, she's coming in and the right eye vision is blurry. She says there's a big spot off to the side that's always dark. She's got a lot of floaters in both eyes and some are dark and some are light. Started bothering her a few months ago. She doesn't usually get headaches and she's been getting headaches starting about 2 weeks ago that are medium in severity and sometimes make her want to lie down. She has multiple things. She has multiple sclerosis, hypertension, arthritis, disc disease. She's had a few surgeries. She's got a lot of medications. I'm just gonna skip ahead because I don't think they're particularly relevant, but she's just on a lot of medications. So her physical exam is mostly benign. Her vision is decent.
Oh, they just started perfect. Yeah, they were doing some like, some of their BS where they're just talking.
This is everybody's on a note like this. Where's the location he's actually talking?
1 second.
Yeah.
Oh, sorry.
That's me.
Spoilers. Okay.
You're gonna show.
Exams only, or at least the anterior exam is only notable for some vit cell in the right eye.
Oh, that's beautiful. You feel bad, but it's very pretty. I just feel bad. It's pretty
So-
Who did that?
Other fundus on the right eye. Lots of these yellow hypopigmented lesions throughout the posterior pole, including kind of the temporal macula. There's some
I'm gonna pause
hyperpigmented centrally.
just to zoom in.
Okay, thank you. So zoomed in to kind of the macula, again, more yellow. Some of them have like a hyperpigmented area centrally. And this is the right eye where her chief complaint is. The disc does look just a little bit blurred, edematous. Like there's one vessel in particular that's kind of blanched out severely. Actually, that one, it just looks like it disappears on you.
I think that's a hemorrhage.
Yeah, you could
Yeah.
tell a flame hemorrhage.
Okay, well, flame hemorrhage, so maybe, yeah, certainly a little disc edema.
Which is interesting. So one little side thing. So she has multiple sclerosis.
Hmm.
So could that just be he's got to ignore everything else. Can it be optic neuritis at this?
Sure.
I mean, her chief complaint certainly, she has like this black spot, almost like a scotoma.
So a little thing that I remember hearing at some of these academy talks, and this hopefully is true, is that the optic neuritis treatment trial, not a single disc had a hemorrhage. So an optic neuritis, and you can ask your dad this, I hope it's true, because I always teach it. My understanding of optic neuritis is that they really never get hemorrhages.
I think that would be like atypical.
Yeah, it'd be
arthritis
super
if
atypical.
they-
If you look at the whole trial and nobody had a disc hemorrhage. So anyway, so it's just a nice, keep in your head that swollen nerve hemorrhage, you can almost always cross off optic neuritis. It's not this case, but just in general. And the other thing about the lesions, what would you say about the age of the lesions? Sort of like if you go to the other one. Like
Well,
you
when
look
they
at
have
chicken-
that pigmentation to them, that suggests like more chronicity.
All right, so they look like they're different ages, don't they?
Yeah, yeah. Some are fresher, some are more chronic. Left eye, and this is more benign looking. I'm not seeing any of those yellow spotty hyperpigmented lesions.
Correct.
And little peripapillary atrophy. Okay, autofluorescence, right eye, the problem eye. So correlating to those yellow lesions, we see areas of hypo-autofluorescence with hyper-autofluorescence. And maybe some of them in the periphery are more hypo-autofluorescent, they're inferiorly.
Yeah, it's a similar comment about the age. It seems like they're slightly different. Some have these more hypofluorescent centers. And then left eye demonstrating.
So OCT with a cross section through one of those lesions. We see some disorganization of kind of the outer retina, maybe loss of that external limiting membrane, ellipsoid zone. You see some kind of bumpy, ratty appearance to that outer retina and ellipsoid zone, and then that hyperreflective signal through the choroid. Yeah. And then this is the left eye, and just like maybe a little epiretinal membrane there, nasally, but really good foveal contour, good preservation of the retinal layers, outer retina in particular. This is a good looking eye.
So I included this.
Show Sabrina the color picture, it's real cool. Yeah, so this is the patient we're doing.
History of PRP or no?
No,
Done by,
Okay.
done by PQ by 2.
Okay, cool.
yeah, it's an interesting case.
In short, no disc elevation.
Not really? What's the number? Let's see,
Yeah,
one
that's surprising
twenty-four.
because it did look
One
edematous.
twenty-four and 10, it's a little bit.
And then we said there was maybe like a Drance hemorrhage.
Yeah, it's a smidge, I guess it's not true, 124 to 1, it doesn't turn red when it's high. I don't think, so we can't tell by the colors, I think it was higher than, I think it's 124 and 103. So it's a smidge.
So, I'll go through a couple of these. But we'll go through the FA series of the right eye.
So an interesting thing on your fluorescein, your early fluoresceins are often a little bit of autofluorescence in them. So if you look at that spot near the fovea, some of that, because we're at low signal, may be if it disappears, that means it's just autofluorescence. So it's not like a window defect, it's not staining, it's just autofluorescence. See, I see what it does, I'm not sure if it disappears or not. Yeah, see, it disappears. So that was just an autofluorescent spot you were seeing. Now, when you get high signal, it slumps it out and it turns into a blocking.
So into the AV phase, getting kind of late into the AV phase now. Kind of just this speckled pattern, splotchy patches of hyperfluorescence and these smaller little zones of hypofluorescence that are correlating to those
Show the mouse.
yellow lesions.
Oh, why don't you take the keyboard and give them the notes? Who's got the keyboard? You can advance through the keyboard. You can go back to the keyboard. Yeah, so point to what you're talking about.
So these little splotches of hypofluorescence may be correlating to those yellow lesions. And just kind of the background is more.
And what about the disc?
The disc looks, again, edematous, maybe potentially some leakage. Let me kind of go through, yeah.
It's a little hot.
It's a hot disc. Expanding, kind of not well demarcated borders, so areas of hyperfluorescence of the disc.
And what about your dark spots?
So that dark spot's the hypofluorescent. I think that is correlating to one of those yellowish, let's see, I'm getting lost here. So this is very late, and this is where you can really, again, appreciate those lesions. So I'm gonna look there. Oh wait, this is the other
Oh, they turned hyper. They're hypo than hyper.
eye. Yeah, so early hypofluorescence.
And you'd say that's staining or leaking on the lesions.
On the lesions, I would say staining.
So we'd say they block early, stain late, right?
Block.
Heard that somewhere before.
Yeah. That's really
Hmm.
on fluorescein. So on fluorescein, you've got these spots that block early, stain late.
Okay, and then left eye. Again, this eye was benign and looks like a nice FA. Well, sorry,
So what kind of image is this?
so ICG, you can really see the choroidal vasculature a lot better.
So what are they blocking early or stain, are they leaking, blocking, staining?
This is pretty late, and this is again gonna be hypofluorescence. And this was late staining?
No, they're blocking. So you'd say block early, block late, right? They just block. They're just dark.
Yeah, blocking, because it's dark, okay.
I guess blocking presumes there's something in the way. I guess you could say they're dark, but we typically say blocking. I don't know what they're blocking exactly. Yeah, hypofluorescent, good.
Okay, so in summary, we saw these yellowish, yellow-gray lesions scattered throughout the fundus in the right eye. Left eye didn't show it much. On autofluorescence, we had the scattered foci of hyperautofluorescent lesions with a few hypoautofluorescent clearings. OCT max showed this, well, demonstrated this one lesion that had disruption of the outer layer. OCT nerve, maybe a little swelling, maybe a transheme, an FA, early hypofluorescent irregular lesions with late leaking. I wrote staining, but could be one of the other. It looked kind of hazy, so I felt like maybe early leaking and then it stuck around. Would you say it's leaking and then
On the nerve or the lesion?
no, for the lesions. Because it stuck around a while. Would it be a leak that stained?
I think probably yeah, it's the fluorescence leak. Yeah, I guess a little bit of leakage in lesions. Yeah,
And then ICGA showed these hypofluorescent lesions throughout all the phases. So differential.
and I like ICG for posterior uveitis, helps a lot. I get it on almost everything.
So differential top is like your white dot syndromes, I think, type of uveitis. Think about infectious etiologies with kind of all those lesions, like syphilis, toxo, pose,
One more.
but TB, yeah.
And which are your white dots? You know, there's when you do block early stain late eye FA, there's a couple of white dots.
I would think about multifocal choroiditis and maybe like a bird shot, but I'm not sure what that's pathognomonic for.
AP.
Is it ampy?
Yeah.
Ampy.
And another one other.
Pick.
Does Azor also?
Azor is a funny one. If you look at the name, it's acute zonal occult outer retinopathy. So the occult means it's very hard to see. So Azor, for most things, Azor, you don't see anything. When Azor was named, it was before the OCTs. So, but your fundus photo and fluorescein, all that should be pretty much nothing.
I don't even consider it a white dot syndrome. This lumped in there, but
Yeah.
there's no white dots.
Being logical about it.
So nicely done. Nailed my foot.
Oh, go back to that. That was a good differential.
So ampy, relentless, placoid chorioretinopathies, like that.
Yeah.
Are you gonna talk about those later?
Not
So
really.
you gotta talk about, well, so what are those? Let's do. Do you know?
Not really. So
They're very hard. It's not the acute, ampy's not uncommon. Ampy's rare. I've seen fewer than 5, but ampy's out there. Relentless and persistent are tricky. Oh, there's one thing not on here. And then multiple chorioretinopathies, but relentless and persistent are sort of ampy lesions that don't behave like they're supposed to. So some of them spread more, some of them recur more. And I heard one talk by somebody who I think wrote the paper on one of them and said they had not seen, I can't remember which one, it said they had not seen another case since they wrote the paper. So they're wondering if it's been 10 or 20 years, if it's been a real thing. So these are, but they're placoid and they look like this one. This is a funny looking eye because it really doesn't, it doesn't look exactly like ampy and it doesn't look like the other one, which you're gonna get to, right? It's sort of like an in-between one.
So
So it's,
unilateral disease, sometimes that helps with the white dots.
yeah.
right.
But I know it's not, like, it's not, it was sent in with the diagnosis of birdshot. It's not birdshot. It's not Muse. It's not, like, you can say all the things it's not. It's either ampy or serpiginous.
Right.
Or the two block.
I feel like ampy, they're bigger and kind of creamier.
In ampy, they get their vision back later. And ampy tends to be younger patients, which you can probably talk about all that, right? Okay, so go ahead, do your thing.
So, so the last one is whether I'm not sure if it's considered white dot, but lastly, it would be serpiginous choroiditis.
Yeah, serpiginous isn't.
Okay. Goes by a few other names, geographic choroiditis and helicoid peripapillary choroidopathy. Classically, it's a bilateral idiopathic inflammatory disorder resulting in this geographic atrophy of the RPE and choriocapillaris. Historically, it was associated with TB or syphilis, but that's not necessarily true. And we, depending on which source you look at, you can divide it into a few subgroups, whether it's classic serpiginous choroiditis or the non-classic serpiginous-like choroiditis and multifocal serpiginoid choroiditis. And those will present a little bit differently. So it's very rare. Very few patients of all the uveitic patients will present with this. It may have a higher prevalence in the Asian countries, may be related to the endogenous infectious rates there, but it's not necessarily clear. Research is still out there. The pathology and etiology of this is pretty unknown. They think there are some T-cell mediated inflammatory pathways, but it's very poorly understood at the moment. But it is this immune mediated vasculitis, possibly with this choroidal vaso-occlusion leading to ischemia. And then for the infectious etiology, like I said, it was historically thought to be TB or syphilis, but there are some papers out there suggesting that there is a viral etiology, or it could be related to toxo, possibly candida. Maybe all of them have some background in playing into this.
I mean, a lot of this stuff probably, don't you think, isn't something, it's gotta be something, you don't have it and then you have it,
Mhm.
and they're funny looking. She was tested extensively, syphilis and TB were, and she actually was hospitalized, saw ID and a bunch of stuff, so we pretty much checked her for everything. But, now we know that, acute, unilateral acute idiopathic maculopathy, is that the one that's probably Coxsackie virus?
Could be, there's like a lot of papers on it.
Yeah, so Coxsackie, so there's a number of, so there are some viruses now getting, and then, there's in the cases with acute macular neuroretinopathy, which are dengue fever. So there are some things that are in West Nile, those funny looking white spots. So I think someday we'll maybe know what it is, but so far we don't.
Mhm. And like Dr. Cohen said, this lady went under extensive inpatient testing for any infectious etiology. It all came up negative. So
And the reason I had to go to the hospital with Sherp, I see Humana patients out of network. I cover them for complicated cases just because they're so busy, which I kind of like, so I get to bring them to conference. And so this was a Humana patient, and I sent the patient to the hospital because of the headache. So with the headache, if it's ampy, I've not heard about it with serpiginous, but if you can get a cerebral vasculitis,
yes.
and you can die. So I sent her to the hospital.
Didn't Grizzard and Hammer have a patient die from that?
Yeah, they had one shortly before I joined them.
On the flip side of that, there's, ampy is associated with the viral infection or the preceding viral infection. So a lot of folks will have headaches.
That's true. Yeah.
So it's not
If
necessarily.
you ask people in the ED if they have a headache, there's different studies. A lot of people there have a headache.
This is true. I get it, like, you're not already.
I get a headache when I'm there.
Yeah.
Okay. So treatment includes immunosuppression. So aggressive steroids initially, and like all the uveitis patients and inflammatory patients, figure out how to suppress long-term without the use of steroids. And then in this lady, for serpiginous, continuous monitoring for progression, recurrence, and complications like CNV and CME. The prognosis is relatively poor, especially as it relates to all the other white dots. The final visual acuity in a quarter of the patients is less than 2,200. So of the white dots, this is one of the more serious ones.
So why couldn't this have been multifocal choroiditis or punctate inner chorioretinopathy?
Well, punctate's too small. Multifocal choroiditis and panuveitis has a little more subretinal fibrosis. But that doesn't have the block early stain late. So multifocal choroiditis kind of stains early and stains late. Multifocal choroiditis on ICG, I'm pretty sure is not dark. Because they're membranes, they tend to be little fibrotic membranes, so there's no reason for them to be dark. So those dark spots are, now I have to say, mudes can look like that. On the ICG, mudes will look dark like that. But mudes on a FA doesn't block early and stain late. So there are little differences between all of them.
So block early stain late is
On the
either
fluorescent
ambi or
serpiginous,
serpiginous.
right? I remember Sabrina presented that last year or 2 years ago.
And I think
Uh,
Jacob
Yeah.
did the presentation.
Yeah. Yes.
I think Jim Fulp was the fellow who showed that immunosuppression chronically reduces the number of recurrences in this disease. He's near the end of his career out in Iowa. We were fellows together. We overlapped. And you should know that people recommend steroids acutely, but the acute lesions will fade over 3 weeks. So it's really hard to know if you're doing anything with steroids in that situation. But James showed that you need to do chronic immunosuppression. I tried to do it on one patient, but he took like 2 pills and said, "I'm not doing this." And he actually had continuous lesions, but he did not get his fovea in one eye. And so last I saw it, I followed him for over 30 years. His eye looked just terrible, except for the fovea, and he could see. It was sort of amusing. But that
I don't know if we're gonna start like with these, with the utiques and all that stuff. Theoretically, you could pop a utique or a lubian in every 3 years and spare them all the systemic medicines. And I was sort of starting to do that with the serpiginous patient, but then she's a snowbird and the doctors up north kept her on systemic.
I missed that. What did you say?
We have these 3-year steroid injections now.
Uh-huh.
So you wonder if you could just pop a steroid in there every 2.5 years, maybe 3, put one of those implants in, and that would spare them the systemic.
Yeah, that would be a good idea.
But it's, it's new.
Yeah.
So, as I was mentioning before, she was admitted for a very extensive workup. All the inflammatory labs and infectious labs were normal and didn't show anything. And she was treated with the high-dose steroids, transitioned to oral steroids, and then eventually transitioned to methotrexate. And she had a very great recovery. These images are from a few weeks after, and you can see that they're starting to resolve. You don't see massive number of those multifocal lesions, and they're starting to dissipate. I don't think I included a photo of really the classic lesion, but this is not the classic serpiginous presentation that we really see in the textbooks. It kind of emanates from the nerve and spreads centrifugally around the fundus. But this is more of a multifocal kind of presentation where the lesions are discontinuous and not necessarily associated with the nerve.
Yeah, if they were more fibrotic, this would be a perfect multifocal choroiditis case. But so it's very close. It's very close to multi, but they're just not quite the right lesions. They're placoid. You don't see those big plaques with multifocal.
Would the treatment be different?
Not necessarily, although multifocal choroiditis, I don't think I keep on chronic treatment. I think I would just quiet them down and stop. I don't tend to keep them young. No.
So I just included this. Earlier I mentioned there's the classic, there's serpiginous choroiditis and serpiginoid choroiditis, which is the multifocal variant. And they said serpiginous like choroiditis, more likely to have a unilateral presentation, relatively younger with multifocal lesions. So I was wondering maybe there's a missed infectious etiology, but there was about to kick us out.
The problem is with this room. Are we supposed to leave at 9 or
No.
usually it's on the door?
11.
Oh, good, okay, we can stay next now. Just to show them, they can stand up at your two. I don't care if we have nowhere to go. I'm just gonna sit in this room.
That's right.
Just to keep that.
Know what my columns say.
So there's very low suspicion for infectious etiology, but I just wanted to kind of highlight that the serpiginous presentation doesn't necessarily need to emanate from the nerve with that classic presentation that we see in textbooks. Is my right?
And the other thing very smart people have always worried about is herpetic, because it just looks, if it looks like a